Before doctors can treat the disease, they have to, define what they're actually looking for. And the briefing gives us a very specific threshold.
Right.
Pulmonary hypertension is defined as a mean pulmonary artery pressure, we call it MPP, greater than 20 millimeters of mercury.
Yeah, 20 is the threshold. Like anything above that, and the alarm bells start ringing for a cardiologist.
And to find that number, the text mentions two different tests. First is echocardiography, which is an ultrasound of the heart, and that's listed as the best initial screening test.
Right, the screening.
But then a right heart catheterization is the absolute gold standard for diagnosis. I kind of want to use an analogy to picture this. Let's compare your standard systemic blood pressure to the main water line of a house.
Okay, I like it.
It's robust, it's easy to access, you can measure it from the outside, but your pulmonary artery pressure is like a specialized, really delicate pipe leading only to your water heater, the lungs.
That's a great way to look at it.
Right. So if an echocardiogram is the best initial screening test and is totally non-invasive, why is sticking a catheter directly into the right side of a patient's heart the gold standard? Like, what does that invasive procedure confirm that the ultrasound can't?
Well, the plumbing analogy works perfectly here. An echocardiogram is essentially like pressing a stethoscope against the wall of your house to listen to the pipes.
Okay.
You can hear the water rushing, you can estimate the speed of the flow, and you can see if the pipes are vibrating under stress. So it tells the physician, hey, we have a high pressure situation going on here.
But it's just an estimation.
Exactly. It's fundamentally an estimation based on sound waves and fluid dynamics.
So it's an educated guess. I mean, a very good one, but still a guess.
Yes, precisely. A right heart catheterization, on the other hand, is the equivalent of installing a physical pressure gauge directly inside that delicate water heater pipe.
Wow, okay.
Yeah, a cardiologist threads a catheter through a vein, usually in the neck or the groin, down into the right side of the heart, and pushes it right into the pulmonary artery. It gives you the exact undeniable pressure number.
That makes sense.
But perhaps more importantly, it allows the physician to measure something called PAB-IUP, or pulmonary artery wedge pressure.
PAL-PP. Yeah, I've seen that acronym all over these notes. What is that catheter actually wedging into?
Right, so the catheter is pushed deep into the branching vessels of the lungs until it literally wedges tight, like it gets stuck.
Wait, on purpose?
On purpose, yeah. By doing that, it blocks the flow from the right side of the heart temporarily, and this allows the sensor on the tip to essentially look forward through the lungs and measure the pressure that's backing up from the left side of the heart.
Oh, I see. So it's taking a reading of the far side of the plumbing.
Precisely. To diagnose true isolated disease of the lung vessels, what the guidelines call precapillary pH, you need that pulmonary pressure to be greater than 20. But you also need that wedge pressure to be 15 or less.
Right, because if the wedge pressure is low,
it proves the left side of the heart is pumping normally, and so the pressure problem is originating strictly in the lungs.
Got it. There's one more metric I'm seeing here to confirm this precapillary diagnosis. It says you need a pulmonary vascular resistance, or PVR, greater than 2 Wood units. I have to admit, Wood units sounds like we're grading lumber, not measuring human heart function. What does that actually mean biologically?
Yeah, it's a funny name. But Wood units measure the actual physical resistance the blood encounters as it tries to flow through the lungs. Think of it as a measurement of stiffness.
Stiffness of the blood vessels.
Exactly. If PVR is high over 2 Wood units, it means the pulmonary arteries aren't just under high pressure. They have physically become stiff, narrowed, and unyielding. The right side of the heart is pushing against a brick wall.
So if the biological weapon is the same, stiff vessels and a struggling right heart, our next step is figuring out the root cause. Because once you confirm those numbers, the World Health Organization divides pulmonary hypertension into 5 distinct groups.
Yes, 5 groups. And you have to get this right.
Right, because treating a patient without knowing their group seems to be a recipe for disaster. The notes give us a mnemonic for the causes, which is LHLCM.
Medical students live and die by mnemonics. I mean, it's the only way to quickly triage a massive amount of differential diagnoses.
So true. So let's focus on groups 2, 3, and 5 first, because these are actually secondary to other bodily failures. Group 2 is the first L in the mnemonic left heart disease.
Which is really common.
Yeah, this includes heart failure or valve issues, and it's the most common cause of high lung pressure. Then group 3 is the H, standing for hypoxia or lung disease like COPD or severe sleep apnea.
Right.
And group 5 is the M for multifactorial. These are complex systemic issues like sickle cell disease, chronic kidney disease, or sarcoidosis.
These groups are crucial to identify because the high pressure in the lungs is really just a symptom of a larger systemic collapse. The lungs are the victims here, not the culprits.
Which brings up something in the text that seems incredibly counterintuitive. Under group 2, the left heart disease group, it explicitly states that standard pulmonary arterial hypertension drugs are not recommended.
Emphatically not recommended.
But if someone has high blood pressure in their lungs, why wouldn't you give them lung-specific blood pressure medication?
Well, let's go back to your kitchen sink for a moment. Imagine the sink is completely backed up and overflowing onto the floor.
Okay, a nightmare, but I'm picturing it.
Right. That overflow represents the high pressure in the lungs, but the reason it's overflowing is because the main drain pipe, representing the left side of the heart, is clogged and failing to pump fluid forward.
Okay, I follow the layout.
If you give a group 2 patient lung-specific pulmonary hypertension drugs, those drugs widen the lung vessels. In our analogy, it's like installing a massive wide-open faucet to dump even more water into a sink that is already overflowing.
Oh.
You haven't fixed the clogged drain. In left heart failure, the left ventricle can't handle the blood it already has. If you artificially widen the lung vessels to push more blood into that failing left heart, you will catastrophically flood the system.
That is terrifying.
Yeah, the patient will literally drown in their own fluid.
That paints a terrifyingly clear picture. You have to fix the drain.
No.
Like treat the left heart failure with diuretics to remove excess fluid,
Yeah.
or fix a bad valve.
Exactly, and you apply the exact same logic to group 3. If a patient's lung pressure is high because the lung tissue is destroyed from decades of smoking, or because severe sleep apnea is starving them of oxygen every night, a specialized blood pressure pill won't fix the hypoxia.
Right.
You have to put them on oxygen, you have to use a CPAP machine, you really just have to treat the root cause.
So if it's not the left heart backing up, and it's not destroyed lung tissue or systemic kidney failure, we are left with group 1.
The primary suspects.
Right, this is pulmonary arterial hypertension, or PAH. This is where the pulmonary arteries themselves are the primary origin of the disease. The mnemonic for this group's triggers is HIPPA, spelled H-I-P-P-A. Can you decode this lineup? Because it looks incredibly diverse.
It is a vast spectrum of triggers. H stands for heritable causes, often a specific genetic mutation called BMPR2.
Okay.
I is idiopathic, which is just a frustrating medical term meaning the disease appeared spontaneously and we have no idea why.
Right, doctor speak for we don't know.
Pretty much. Then the first P stands for pills and toxins, and the literature specifically highlights methamphetamines as a major culprit.
Which is a completely different origin than a genetic mutation.
Vastly different. The second P covers portal hypertension from liver disease, as well as congenital heart defects. And finally, the A stands for autoimmune conditions, specifically connective tissue diseases like systemic sclerosis, as well as viral infections like HIV.
Looking at that HIPPA list, you have illicit street drugs sitting right next to hereditary genetic codes and autoimmune diseases. How do such wildly different extremes all result in the exact same cardiovascular disease?
To understand the common denominator, you have to look at the inner lining of the blood vessels, called the endothelium. You can picture it kind of like the non-stick coating on a frying pan.
A non-stick pan, okay.
When it's healthy, it's perfectly smooth. It allows blood to glide effortlessly, and it secretes chemicals that tell the smooth muscle around the vessel to relax and stay wide open.
So it's basically the traffic controller for the blood flow.
Precisely. Now, whether that delicate lining is attacked by a mutated protein from your genetics, or ravaged by the severe chemical toxicity of methamphetamine, or mistakenly attacked by your own immune system in systemic sclerosis, the result is identical.
The non-stick coating gets damaged.
Heavily damaged. This is called endothelial dysfunction.
And how does the body react to that damage?
Yeah, it panics. The damaged endothelium stops producing the chemicals that keep the vessel relaxed and starts massively overproducing chemicals that cause the vessel to clamp down.
Oh.
Worse, the smooth muscle cells surrounding the vessel start multiplying out of control, growing inward. So over time, those flexible, wide pulmonary arteries physically remodel themselves into tight, rigid, thick-walled tubes.
So the trigger might be different, but the biological consequence is exactly the same.
Yes.
And there's a fascinating test mentioned during that right heart catheterization, specifically for idiopathic, heritable, or drug-induced cases. It's called a vasoreactivity test.
Yeah, that test is essentially asking the blood vessels a question. Are you permanently scarred solid, or do you still have the ability to relax if we give you a powerful chemical command?
Right.
They administer a fast-acting vasodilator during the catheterization. If the pressure drops significantly while the heart keeps pumping normally, the patient is considered vasoreactive. It means their vessels can still open up, which changes the entire treatment pathway.
Which brings us to the treatment arsenal for Group 1. Because we're dealing with a localized problem where the pipes are actively clamping shut, doctors use a highly specialized pharmacological attack. The mnemonic here is endo-pro-no.
Right.
Sounds like a cheat code, but it actually outlines the 3 biochemical pathways we can manipulate to force those vessels open. Let's walk through them.
Sure. The first is endo, which targets the endothelin pathway. Endothelin is a potent chemical your body produces that causes vasoconstriction. It makes the vessels clamp down.
Okay.
In PAH patients, endothelin is severely overproduced. So we use endothelin receptor antagonists, drugs like bosentan, ambrisentan, and macitentan to block those receptors and stop the clamping.
Okay, so that pathway is all about blocking the bad signal. Then we have the no pathway, nitric oxide. The pathway promotes vasodilation. It widens the vessels.
Yes, exactly.
I'm looking at the drug list here, and it includes sildenafil, tadalafil, and riociguat. Now, most people recognize sildenafil as Viagra. It feels a bit jarring to see it listed as a life-saving lung medication.
It surprises many patients, but smooth muscle relaxation is smooth muscle relaxation, whether it's in the pulmonary arteries or elsewhere in the body.
Fair point.
Sildenafil and tadalafil are PDE5 inhibitors. They essentially trap the nitric oxide signal in the smooth muscle cell, forcing it to stay relaxed and wide open. Riociguat works on the same nitric oxide pathway, but through a slightly different mechanism. It directly stimulates the enzyme that creates the relaxation signal.
But the clinical briefing has a massive bolded warning right here. It says riociguat must never be combined with PDE5 inhibitors like sildenafil. Why is that combination so dangerous if they were both trying to achieve the exact same goal?
Combining them is like pressing the accelerator of a car to the floorboard while simultaneously cutting the brake lines.
Uh-oh.
Yeah, you are hyperstimulating the exact same biological pathway with 2 massive chemical hammers. The vessels dilate so fast and so intensely that the patient's systemic blood pressure can completely bottom out.
Oh.
It causes a catastrophic, potentially fatal drop in blood pressure.
Point taken. Respect the pathways. The final part of the arsenal is the PRO pathway. prostacyclin. These drugs include treprostinil, iloprost, selexipag, and epoprostenol. The notes say treatment is risk-guided.
Right, it's reassessed all the time.
Yeah, like a low or intermediate risk patient starts with dual oral therapy, meaning they take 2 pills to hit 2 of those pathways. But for high-risk patients, it recommends upfront triple therapy. And it specifically isolates epoprostenol as the heavy hitter, noting it is the only therapy consistently shown to improve survival in severe cases. What makes epoprostenol so much more effective than just taking 3 pills?
It comes down to the aggressive nature of the drug and the mechanics of delivery. Epoprostenol is a synthetic version of prostacyclin, which is the most potent natural vasodilator the human body produces. But it has a remarkably short half-life.
What does that mean in practice?
If it's in your bloodstream, your body breaks it down in a matter of minutes.
Oh, wow. So you can't just swallow it. It would be gone before it even reached the lungs.
Exactly. To be effective, epoprostenol has to be given as a continuous intravenous infusion. That means 24 hours a day, 7 days a week, delivered through a permanent central venous line implanted in the patient's chest. And it's hooked to a small pump they carry with them everywhere.
That is a massive lifestyle commitment.
It really is. But because it is a continuous, overwhelming flood of vasodilation directly into the heart, it physically prevents those diseased vessels from slamming shut. It unloads the pressure on a failing right ventricle like nothing else in modern medicine.
That is an intense level of lifelong management. But the briefing pivots incredibly dramatically when we reach group 4. This is CTEPH, or chronic thromboembolic pulmonary hypertension. This is the C in our original LHLCM mnemonic.
Right, CTEPH.
The guidelines say to suspect CTEPH if a patient has shortness of breath that persists for more than 3 months after a pulmonary embolism, which is a blood clot in the lung.
Pulmonary embolisms are quite common. Usually, a patient is put on blood thinners, and the body's natural enzymes dissolve the clot over a few lengths. But in a small percentage of people, that clot doesn't dissolve.
And the briefing insists that a VQ scan, which maps airflow and blood flow in the lungs, is absolutely mandatory to screen for this. The reason it's mandatory is what blew my mind.
Oh, I know what you're going to say.
Under the treatment section, it says the first choice is a pulmonary endarterectomy, and if the patient is operable, this disease is actually curative. We've spent this whole time talking about managing chronic cellular damage, and suddenly we're talking about an outright surgical cure.
It is one of the most remarkable procedures in cardiovascular surgery, and it highlights the absolute tragedy of misdiagnosis.
Okay.
If a physician misdiagnoses a Group 4 CTEP patient as a Group 1 PAH patient, they will give them pills to dilate their vessels. But those pills won't work because the vessels aren't clamping down from cellular panic. They are physically blocked by old blood clots that have calcified into hard, fibrous scar tissue.
Like pouring concrete into the pipes. No amount of medication is going to widen a concrete blockage.
Exactly. So the right heart continues to fail, and the patient slowly declines. But if the VQ scan catches the physical blockage, a specialized surgeon can perform a pulmonary endarterectomy. They literally open the patient's chest, place them on a cardiopulmonary bypass machine, and actually cool the patient's body down to deeply hypothermic levels.
Wait, why do they cool them down?
So they can completely stop blood circulation for short intervals.
They completely stop the blood flow.
Yes, they need a bloodless, perfectly clear view inside the lung vessels. Then, using incredibly precise instruments, the surgeon delicately dissects and peels that fibrous scar tissue away from the wall of the pulmonary artery.
That is unbelievable.
It is akin to pulling a perfectly formed branching cast out of a mold. Once that blockage is peeled out, the pressure drops instantly. The right heart can breathe again. It functionally cures the patient.
That is a staggering mechanical feat. I mean, wow, if the blockage is too deep and is deemed inoperable, the notes mention balloon pulmonary angioplasty, basically using balloons to stretch the vessels open, along with the drug riociguat and lifelong blood thinners.
Those are the backup options.
But finding those operable cases is clearly the ultimate goal. Moving on to the broader picture, the text provides a universal management checklist for anyone living under this kind of cardiovascular stress, regardless of their specific group. The acronym is ODERS.
Odors.
Oxygen, diuretics, exercise rehabilitation, risk factor modification, and specialist follow-up. I want to drill down on the risk modification part. It lists getting flu and pneumonia vaccines, which obviously makes sense for vulnerable lungs, but it also explicitly mentions managing iron deficiency. Why is iron so critical here?
Well, your heart is working furiously, burning massive amounts of energy, and it is desperately hungry for oxygen. Iron is the fundamental building block of hemoglobin, which is the vehicle that carries oxygen in your red blood cells. If a patient is iron deficient, their blood literally carries less oxygen per drop, so the heart has to pump twice as fast just to deliver the bare minimum of fuel to the body. For a right ventricle that's already on the brink of failure, that extra workload is catastrophic.
Which perfectly explains the most severe warning in the ODERS mnemonic, avoid pregnancy in PAH. It's stated so starkly. Just how much physical demand does pregnancy place on a person's cardiovascular system?
People vastly underestimate it. When a person becomes pregnant, their overall blood volume increases by roughly 50%.
50%, that's huge.
It's massive. The heart has to physically pump 50% more fluid every single minute of every single day to support the fetus. A healthy, flexible heart adapts to this stretch. But in pulmonary arterial hypertension, the right ventricle, which is naturally a thin-walled, low-pressure pump, is already hypertrophied.
Right, the muscle is thickened from fighting the high lung pressure.
It is exhausted, and it is fighting against rigid pipes. If you suddenly inject 50% more blood volume into that closed high-pressure system, the right ventricle simply cannot handle the fluid overload. It dilates, it fails, and historically, the mortality rate for both the mother and the fetus in these situations is devastatingly high. It is a critical survival imperative to avoid it.
Which brings us to the ultimate warning signs. The clinical briefing closes with a set of red flags that predict a very poor prognosis, grouped under the acronym BDRV.
A very fitting acronym.
Very fitting. The B stands for high BNP or NT-proBNP levels in the blood. We see those acronyms constantly in cardiology. What do they actually represent on a biological level?
BNT is essentially a chemical distress signal. When the right ventricle is trying to push against that massive lung pressure, the muscle fibers literally stretch.
Okay.
If they stretch too far and the heart muscle is physically tearing at the seams, the cells secrete this hormone directly into the bloodstream, just screaming for help. High BNP means the muscle is physically failing.
The rest of the BADRV signs follow that same grim logic. A is for increased right atrial pressure, meaning the backup is reaching the top chamber of the heart. D is for a low distance on the 6-minute walk test.
Which is a very common functional test.
Right, and the text specifies less than 320 meters in 6 minutes as a major red flag, showing the patient's functional capacity is severely compromised. R is for clinical signs of right ventricular failure, like massive swelling in the legs. And V is for syncope, which is fainting from a lack of cardiac output.
Yeah, those BADRV signs are the objective markers that the right side of the heart is actively losing the battle against the lung pressure. It tells the specialist that whatever intervention they are doing, they need to escalate it immediately.
We have covered incredible ground today. We started by diagnosing that hidden lung pressure with a right heart catheterization, proving the pressure is over 20 and the resistance is high. We categorized the chaos into 5 distinct WHO groups, making absolutely sure we don't accidentally flood a failing left heart with the wrong drugs.
Crucial step.
We unpacked the endo-pro-no chemical arsenal to force rigid vessels open, marveled at the surgical reality of peeling a blood clot out of a lung, and examined the immense mechanical strain this disease places on the right ventricle.
It's a prime example of why precision in medicine matters. You cannot treat a patient effectively if you don't fully understand the mechanical root of their high pressure.
I couldn't agree more. And leaves me with one final thought to ponder. As we look at how complex this diagnosis is, requiring invasive catheters and constant monitoring of BADRV signs, you have to wonder where technology takes this next.
Oh, absolutely.
We already use artificial intelligence to scan thousands of standard echocardiograms. It makes you wonder how soon an AI algorithm will be able to detect the microscopic vibrations of right heart strain on a routine ultrasound, catching pulmonary hypertension years before a patient ever feels short of breath.
That would change everything.
It really would. It's a profound thought to take with you today. Thanks for joining us on this deep dive. We'll catch you next time.